Hello everyone, my name is Irish and I welcome you all to this amazing episode of Tea Talks powered by Transgender India. Today we have an amazing guest. Please welcome Dr. James Roy from Roy's Cosmetic Clinic, Combo 2. Let's begin with our first question. So, doctor, if a transgender person wants to contact you, how would they be able to consult you and what is your consultation fees?
See, consultation fees, something between 300 to 500 I charge. Uh, you know, Sometimes I reduce the charges to 300. Otherwise, it is usually 500 rupees is the consultation.
Okay, wonderful. Thank you, doctor. Let's move on to the next question. Can you briefly describe your background, particularly in gender affirming procedures? How many years have you been performing double incision mastotomies? Approximately how many double incision mastotomy procedure have you performed?
Yeah, that's a good question. See, I was in my earlier career, I was in Middle East. So maybe 2006, I came back to India, settled down in Coimbatore. Then actually, I think I started with first case in 2007. Double incision mastectomy may be a bit delayed. 2008 or 9, I would have started. Maybe now around 20 odd cases I would have performed. My main work is on the chest feminization in trans men.
Oh, great. Let's move to another question. Can you explain what a double incision mastotomy entails and how it differs from other types of mastotomy?
Yeah, the double incision mastectomy is mainly done for the male chest reconstruction. So the main concept is we have to create a masculine chest. So we take care and remove all the breast tissue, especially the inframammary fold where it shows up in females. So in males, the inframammary fold is not there. So we take care and remove the inframammary fold, connective tissue, and the entire breast tissue in a double ellipse. That means one ellipse on the right side, one is on the left side. So maybe that is the reason it is called double ellipse. Otherwise, all the other mastectomies done are for other purposes. Usually, it is one-sided. So this is the most likely reason why it is called the double ellipse.
Perfect. Are there different techniques within the double incision method that you employ?
Yeah, see the double ellipse when it comes to the lateral side on the chest wall, depending upon the soft tissues of the chest, sometimes we may have to go along the axilla as a horizontal line. Nowadays, I restrict and take it up to the axilla so that it falls within the shadow of the pectoralis major muscle. So that gives a nice aesthetic appearance after reconstruction. So this is the one which I am slowly modifying with a straight ellipse to a oblique ellipse.
Okay, great. What criteria must a patient meet to be a good candidate for this surgery?
Now, mostly I see them all young, healthy adults, and some people are on testosterone hormone. So I ask them to stop 15 days earlier. Otherwise, the blood oozing complications are a bit higher. So otherwise, we do the basic blood tests like hemoglobin, sugar, urea, creatinine, bleeding diathesis, and serology. Most of them are straightforward persons for surgery.
Okay. What pre-operations are necessary for patients?
Pre-operative test, you mean? Lab test?
Yeah, yeah.
Yeah, I do the complete blood count, that is RBC, WBC, platelet count, hemoglobin, and kidney functions, mainly urea and creatinine, and bleeding time, clotting time, INR, prothrombin time. Then maybe because since they are not nutritionally defective, we don't do the proteins and the serum proteins and the serum hepatite, that is HBS, that is AG hepatitis, or SCV or HIV, and VDRL. These are the tests we do before undertaking any procedure.
Doctor, any documentation required, any specific health or lifestyle requirements for patients before undergoing this surgery?
Yeah, since it's irreversible surgery, our WPATH SOC 8 requires mental health professionals certification before we take up for the surgery.
Okay. What are the common risk and potential complications associated with this procedure? And how do you minimize this risk during this surgery?
Yeah, see, now we have really every day, every surgery, we are making it more better than perfection. That is, nowadays we do it. This procedure usually takes around 4 to 4.5 hours, but we try to do it in the only sedation. It's called total intravenous sedation. So you need not use a general anesthesia, put a tube into the trachea, so that avoids a lot of complications. They just sleep, and we use local anesthesia for the incision, and so the anesthesia risk is reduced considerably less, and we make a very perfect hemostasis and very good approximation with absorbable sutures. And the planning is the very important thing. When we plan the incision symmetry and where the areola, male nipple areola is a very small and very definite. So we plan the nipple areola in a perfect way, and I do the nipple reconstruction with a different technique, with a modified skate flap locally itself. So aesthetically, it is very good, hypopigmented, sensation is present. So with all these precautions, and nowadays all this, my 20 cases, I have never used a drain. Previously, even still now, a lot of doctors use 2 drains. They leave it for 4 to 5 days. We don't use any drain. We give them a compression garment on the table itself, and we do it as a daycare. They can go back home the same day.
Great. What kind of pain can I expect from this surgery? Will I be aware of any pain when the surgery will be performed? How is post-operative pain managed for patients?
Yeah, this is a very good question. See, pain relief is the biggest thing for any person. So IV sedation, one thing I tell my anesthetist is, anesthesiologist, patients should not have any subconscious awareness. When we are doing the surgery, they should not feel anything. Second thing is, they should not have any vomiting in the post-operative. And the pain, we use a lot of local anesthesia. At the end of the procedure also, we give local. So it takes care of pain for 4 to 5 hours. And since we are not using, or we are not touching the muscles, the pain is relatively less. And what we are using is just a paracetamol 1 gram 2 times. Some patients we add Brufen 400 milligrams 3 times after food, along with pantoprazole tablets for 4 to 5 days. That usually, most of them didn't have much pain.
Great, doctor. Can you walk us through the steps of the procedure from consultation to surgery and recovery?
Yeah. See, whenever I see a new patient, I explain to them what we are See, I have to appreciate your community. They know what they are going to undergo. They have, what you call, properly guided by persons who have undergone this surgery, and they themselves know. They come and ask me. See, there are other methods of chest masculinization. If it's a very small sized breast, like a gynecomastia, what we call in male, we can avoid this double incision. We can just do a liposuction and remove the gland. That is not suitable in most of the time. It's very ideal only a small breast. And another type of a breast, if it is a small breast with the nipple areola very small size, we can go for a subcutaneous mastectomy from a what you call IMF, lower incision. That is intermammary fold. We can just raise a skin pocket and remove all the gland and just close the skin, subcutaneous mastectomy. That is also suitable only when the nipple areola is small. Most of the time, the breast is big, nipple areola is big. So we decide for double ellipse mastectomy. Then once I explain with my pictures, this is how the scar going to be. Then once they agree, then next thing we check for the mental health person's certification. Third thing is the lab test. Once their hemoglobin is about 10 and all other parameters are within normal limits, I ask them to come next day morning. They will come around 9 o'clock to my daycare center with the 5 hours fasting, nil by mouth, no liquid, no food. Then around 10 o'clock we start. As I said, we do it mostly on IV sedation, and it goes usually for 4 hours. And they wake up immediately. And once the surgery is over, we give the garment, the chest vest on the table itself, and we advise them not to move the shoulder for 2-3 days. Not much of a shoulder movement, no weight lifting for 3 to 5 days, no driving two-wheelers or any kind of driving for 3 to 4 days. And by evening, when they are fully recovered, when they have voided urine, they have taken fluid without vomiting, they go home. And I call them back on the third day, because by third day, if any hematoma, that means blood collection in the operated area, that will be visible. I change the outer dressing and put a new dressing and call them back on the 9th day or 10th day and remove the tie-over dressing for the nipple areolar graft which you have used to create the areola and the nipple. Then after 1 month only, I give them some scar creams, and when they come for 1 month, I do a screening, superficial screening, any seroma, because I told you I don't use drain. So in the third week is the common time in case any fluid collects. By third week, we do a screening, and so far after 20 cases, nobody has developed any seroma which needed an aspiration. Then maybe once in 3 months, just for a scar management. Some scars go for thickening, so they need some scar management by silicone sheet, massage, injections, like that.
Great, doctor. What does the immediate post-operative care involve? How many weeks is the typical recovery period? Are there any specific post-operative restrictions or lifestyle changes required?
Yeah, see, this is a chest surgery we are doing on a very strong muscle. So the chest muscles should be given rest. So after a surgery, there are chances that it can bleed. So less activity of the upper trunk muscles, pectoralis major, that is, which is mainly the shoulder movement, lifting heavy objects. So 5 days we give antibiotics, and the pain tablets depending upon so we prescribe for 5 days. We tell them if there is no pain, don't take the painkillers. Then second day with the dressing is all waterproof dressing. Second day they can have a shower also. Shower and gently wipe. And we give them some body moisturizing creams. And for the 3 weeks, they should be a little careful in the chest movements. By 3 weeks, 70-60% of healing has taken place. After that, the chances of any complication like wound breakdown, infection, all these things are less.
Correct. What sleeping and resting positions are recommended to optimize comfort and support during the initial recovery period?
Yeah. See, since it is the incision comes to the armpit, a lot of people ask, sir, can I turn one side and sleep? Because most of the people want to lie on the face. So that is, we don't lie on the face, that is chest on the bed. That can produce some shearing force or pressure, which can lead to hematoma or wound dehiscence. But they can turn. We advise them to use the garment which we give on the table 24 hours for 1 week. In between some. So with the garment on, the chances of hematoma or wound breakdowns are less. So they can turn to one side and sleep, but not with the full face down position.
Can you explain how nipple grafting is performed? How does the procedure impact nipple sensation or value?
Yeah. See, when we do the mastectomy, we harvest the areolar skin like a donut. And that is used to reconstruct the areola, that dark pigmented part of the nipple areola in a male. The nipple is reconstructed by a small skin, 5 millimeter width, semicircle with the two, what is called modified skate flap. So the nipple is reconstructed by the chest skin, but the areola is grafted from the areola of the breast, which we harvest and fix it in a tie over. We keep a lot of gauze and tie with the silk so that it nicely gets adherent to the chest wall. This is the areolar graft, nipple areolar graft.
Great. Doctor, how do you address complications like asymmetry or uneven nipple placement?
Yeah, it can happen because if you properly plan from the beginning where the nipple should be, whether it should be oval or circular, and measure twice, cut once. So what I would say, properly take time and measure, mark it again and again. At the end only you cut. Make measurements from the chest wall to the nipple areola, then the incision level. All these things you have to repeatedly check before you make a cut. Then you can avoid the asymmetry, one nipple high, one nipple low, all those things you can avoid.
Of scars can I expect? Are there any precautions or steps I can take best scars healing? And in case my body makes bad scars, can I do something to reduce them later?
Yeah, the scar uh, in any surgeries in the chest, especially closer to the midline, they are prone for hypertrophy. What you say is, see, any scar should stop at one stage and it should settle down. But if it overgrows, it is called hypertrophic scar or keloid scar. Some scars are symptomatic like itching, pain, and growth. So that is one of the commonest thing we tell them how to prevent. It is better to prevent rather than treat. So as the wound starts healing, good compression by means of this vest, and we give scar creams which to be applied 2 times in a day, and gentle massage. All these things will prevent if you have to do it for nearly 3 months. So during this 3 months, when they come for follow-up, if you feel that the scar has a tendency to become thicker, you have some injections which you can give it right into the scar. Then the scar will become softer. Some patients, even the scar is very refractory to treatment. Sometimes we tell them you can revise the scar, remove the scar and suture it again. These are all the methods of scar control.
Okay, so let's go to the next question. What are doctor years? What precautions can be taken to prevent it? What are my options in case I get dog ears and their cost?
So Eric, very good. You know what is dog ear?
No, that's why I asked you.
But you have seen a dog's ear.
Yeah.
It is like this. See, it is like, so what happens when we do a double ellipse? Sometimes one incision, lower flap is longer than the other. So you are trying to close. So the end, it comes like this. You understand? So there's a bulge. That is one reason. Second thing, some people, the axilla, the fat is more. So we do a liposuction, and there are some methods of correcting the extra length. We correct the dog ear and close it again. So two methods: liposuction if there is a lot of fat, and we adjust the incision length and make it same length and close. There won't be any dog ear. Dog ear is the extra bulge you see on both sides of the incision.
And what will be their cost
Which one?
if I get the dog ear?
No, dog ear, if you catch it in the operation table itself, we can correct it.
Okay.
So otherwise, we have to wait for 3 months. Sometimes this dog ear shrinks itself. Otherwise, it is going to be a small procedure. We decide the cost that time, maybe 10,000, 15,000, like that. We have not, so far we have not had any dog ears.
Doctor, do you have any specific HRT regime recommendation pre and post operator?
So by 15 days, we ask them to start their, testosterone. So start 15 days earlier, the surgery, and they can resume in another 15 days time. They can go back to testosterone regime. Usually, I get the advice from the endocrinologist. I don't manage that HRT part.
Thank you so much, Doctor, for today's amazing session. And if you want to know about transition, don't forget to subscribe to Transgender India. And we will meet in next interview. Take care of yourself.
Okay, thank you very much. Nice talking to Harish.
Same.
Okay, Harish.